thank you everyone for joining in on this webinar. I hope you're all as safe and well as possible. Turns out I just heard nearly 2,000 registrants for this event, which tells me that the topic is very timely, and I guess more importantly, our two guests are in very high demand. So as you can see on the slide, today's topic is how COVID-19 will change healthcare forever from patients, payers, and providers' perspective. And as I think about these changes, some of them are quite obvious. For example, I think many of us have already seen the rapid adoption of telemedicine. But at the same time, some changes are less obvious. Things like new ways in which scientists are sharing information and collaborating across national borders. So to discuss these changes and what's happening in the world right now, we have two main guest speakers, Dr. Bob Kocher and Dr. Don Berwick, and both will share their remarks first, and then I'll conclude with my own observations how telemedicine has already evolved. And at the very end, we'll open up for Q&A for about 10 or 15 minutes. So to get started, let me introduce Dr. Bob Kocher. And quite frankly, I could spend 10 minutes just reading his very, very long resume. So I'll keep this extremely brief. Bob Kocher, MD, he is a partner at the venture capital firm Venrock, and also serves on the state of California's COVID-19 response team. And prior to Venrock, Bob served in the Obama administration as special assistant to the president for healthcare and economic policy on the National Economic Council. And among many other things, he was a key architect behind the Affordable Care Act. And before that, he also worked at the McKinsey and Company. So I'll just pause there and let Bob take it over from here. And thank you so much for joining, Bob. Over to you.
Thank you for that super embarrassingly generous introduction, Sami. And thank you for joining us today. I would also say I can't wait to hear Don's remarks. Don's been a hero of mine and a partner trying to make American healthcare better and healthcare around the world better. For the past 4 months, I've had the privilege of helping the state of California begin and think through our response to COVID-19. What I start by saying is COVID-19 is a once in a lifetime, hopefully, pandemic that we must take very seriously, that will exist until we have a way to treat it, either with a great therapeutic or with a vaccine. And the virus really exists to spread. And so we need to take it seriously and do all we can to help protect all of us around, all those around us and ourselves and our loved ones, and not let our guards down. 4 months ago, I joined the government of California to work on our response, and this is our team of folks that was working initially on this. You'll see on the left Todd Park, who many of you will know from being the person that rescued healthcare.gov, and DJ Patel, who was a data scientist for America. This is Mike Welkening, Secretary of Health, Charity Dean, Department of Public Health, and Jenna Hussein, an engineer. And we initially were brought in to help support the epidemiological modeling of COVID-19. And what we knew in March is that the COVID-19 virus will on average infect 2.5 other people per person that it infects. And when you do the math on something that's growing geometrically, what you see is the following. You see this tsunami of infections, which quickly surpasses the hospital capacity that we had in California, which is the red line. And that leads you, as a governor who wants to protect lives, to say we need to do something to change that curve. And so that led to the shelter in place or stay home order, which was put in place in California on March 17th. And this was actually the first draft of it that we worked on, with our goal of figuring out all the things we can do to reduce the number of contacts per day that people have. The way the virus spreads is through sharing breath, the respiratory droplets and the aerosolized virus. And so we wanted to find ways to separate people so we wouldn't be breathing the same air and spreading the virus. And so we put in place everything we could think of to reduce the number of contacts people have per day. And then thirdly, I've spent most of my time over the last 3 months working to help ramp up testing in California. Testing in America has been a challenge for every state. And so I helped create a public-private partnership, which is a testing task force. And our job was to coordinate all of the good intentions and efforts and capacity that we have in California to make sure that all Californians have rapid access to diagnostic testing, and that all of our labs are supplied properly so we can conduct the tests quickly, so we can identify the cases. And what you can see is we went from about 2,000 tests a day in March to now about 100,000 tests a day today. And so we've had good luck at scaling up testing, and that's helped us learn a lot more about the epidemiology and spreading of this virus. If I go to the next slide, let's see. What you can see is that the shelter-in-place order has had a very positive impact on reducing the number of contacts. This is data from the first few weeks of having people stay home, and what you can see is that people's activity, in a good way, dropped off at virtually every, in virtually every way in every dimension that we could see it. We were fortunate to be able to work collaboratively with Facebook and Google to have them share data on people's locations so we could verify that people were staying home. We saw this throughout the state, but it was most dramatic in the urban, in San Francisco and LA, and that had a very positive impact actually on the spread of the virus. We saw it in traffic in California. If you've driven here, you realize that you normally can't speed. People are now, thanks to the fact that the freeways have been much more empty. We saw stunning drop-offs in traffic jams all across the state, like 97% reductions in traffic in Oakland and 96% in LA. We've since had some recurrence of traffic, which speaks to the fact that people are fatiguing with staying at home. And what you can see is actually the results, which are mixed. On the one hand, this is the initial chart of infections that we had anticipated. And you can see that, we had thought by now that we would have many, many more infections than in reality. And so that's a good thing, is that we flattened the curve dramatically and our hospitals did not overflow, and we didn't have a bunch of deaths as we had forecast. The hitch is what's happening now. And so you can see over the past few weeks as we've relaxed some of the stay-at-home orders and people have gotten more tired, I think, of the behavior changes that they've had to put in place. We've had our cases go up quite a bit. And over the last week, we've had a record number of cases. And today we've had 149 new cases, which obliterates the prior record of 5,000. Our deaths number has been quite stable, which on the one hand is good, I suppose, but we had hoped it would be going down at this point in time, and we aren't seeing that either. And so I sit here today with sort of a mixed feeling for how we're doing. We did better than we had expected, and we really reduced the infectivity of the virus initially. But particularly in Southern California, we're seeing the infectivity go back up in ways that are worrisome. It's particularly problematic in nursing homes where it can spread very quickly. And so a lot of work needs to be done to make sure that we make them safer and do better screening of both the staff and the residents in nursing homes. The question is now sort of what happens next. And so I told you that when we began, we thought we were going to have this big initial wave, and in fact, it was flatter. The question is sort of what comes now. Are we now kind of heading into a second wave? Dr. Fauci yesterday in his Senate testimony or his House testimony talked about the possibility of really seeing a surge as we go back to school in the fall and as flu begins. Are we going to be able to contain the virus, much like Europe has done, with excellent contact tracing and great testing? Or are we going to be so fortunate as to have a more Asian-style full control situation where we really do isolate cases and keep them from spreading to new people? There's some big scientific questions that we're all thinking about and working on. The degree of protection that comes from antibodies is not certain yet. And how long antibodies last is also a question. Some of the early data suggests that antibodies offer some protection, but they may not last very long. So you could imagine a situation where we will get coronavirus vaccines when one exists, hopefully every year in a flu-like way. There may be some seasonality, but it's uncertain as to whether or not summer is the less sort of scary period relative to winter. That said, with the growth of cases in much of the warmest parts of the country, it's unclear that there's seasonality. And then there's questions about how infectious are people who are asymptomatic. A very unusual feature of this virus is that about a third of people who get it seem to have no symptoms or have very mild symptoms. And many people think that they are just as infectious as people who have full-blown fever and cough, but there's more work to understand exactly what's the effect of people who have more mild cases and also children who are infected. It's possible to avoid a second wave. I'm just showing you data here from South Korea, but I could have picked Singapore or Taiwan or China or Finland. There's a bunch of places. You can actually push cases down to near zero if you have excellent testing, both of people at the first onset of symptoms, but importantly, of also asymptomatic people. You need to, with all who are infected, have them isolate so they don't spread it to 2.5 to 3 more people. That often means that you need to have new places for them to go so they don't go infect their entire household. So in many countries and in California, we have hotel rooms where we can put people to isolate. You need to reach all of the people that they've been exposing. So people who they spent more than 15 minutes of time with in a room, and have them isolate and be tested too. We need to then take extra precautions to screen workers in the most high-risk settings, so nursing homes, jails, homeless encampments, and other sort of high-density locations. Screening is very, very important so you don't have a person quickly reseed a population. Then you have to think about what do you do about people coming from high-infection places. You're hearing Europe begin to say that they would like to restrict travel of Americans to Europe to control reseeding. Within America also, we need to think about how we think about movement of people across geographies, or at least have them isolate before they spread themselves across geographies. Many of you are working at large employers and universities and thinking through how do you get back to work. And so there's 6 big questions that all of us are grappling with right now. And that includes who's responsible for safety in the workplace and if workers get sick. How do you accommodate those workers who are higher risk or live with people who are higher risk, because you don't want to put people in harm's way. With contact tracing that you'll have a lot more absenteeism of workers as they are called by the contact tracing teams and asked to go home and isolate themselves and get tested. And so you'll have to be able to accommodate that. And then there's a question about how do you create confidence for people to engage in the workplace and to engage in commerce and transact. And so there's additional steps that you may have to take as an employer to sort of give people the assurance that it's safe to do business. This is my sort of current view of how this will look. I think that if you're going to congregate a large number of people, it's very likely that you will need to have some form of screening programs. If I were designing those, I would recommend that you do antibody testing first of one of the high quality antibody tests. The Roche one's a triplex test that tests IgA, IgM, IgG, which is the most comprehensive one. Because you want to be very confident in the results, you'd likely repeat those tests 2 times. And if positive both times, you could say the person has antibodies and it has some degree of protection. For those who are negative, which would be 95% of people probably, then you would do serial PCR testing to find out if somebody's actively infectious. And depending on the job type and the risk of the employee, you would do those tests every week to 2 weeks for those who are at higher risk, and every 1 to 3 months for those at lower risk. There'll be a bunch of modifications to the workplace that will make sense. You'll want to create physical distancing and do your best to create great ventilation. People who are in high-risk roles should have PPE. You would want to have small group, not large group meetings, and do what you can to not have as many people co-located in an office at the same time. Telework, I think, should be definitely encouraged. For consumer confidence, you could imagine there'll be certifications that workers have been COVID tested and they're COVID free. If you're going to have group activities, that there must be testing, that many things will be appointment based to limit the number of people. For universities, you'll see a lot of virtual learning where you only bring people together when you need to. So wet labs, you would put them together. Classes taught in studios, you do in small groups. But generally speaking, large groups you would try to do virtually. For housing, you'll have to work on density to have it be lower. I think athletics will be fraught and hard to do. And food service will have to be incredibly rethought. For K-12, many of the similar modifications are going to be important. A key there is going to be to not mix the students, but try to have the teachers move to the kids and the kids not, keep them in cohorts per day. So you don't have to have a whole school get sick at one time, that you could instead isolate outbreaks to just certain classes. And the courts are a critical area that need to be rethought. Video testimonies beginning to be done, and testing of jurors and of the court staff are going to be essential too to make them safe. I think we're going to have some broad, lasting, and in some cases, good changes that come from this. In healthcare, what you'll see is the virtualization of many things. And the beauty of virtual care is that you can actually deliver more care in small doses. One of the most wonderful parts of virtual care is that you can check on a patient every single day and see how they're doing and make adjustments in real time to help them do better. You can learn a lot about the patient by being in their home with them and make much better recommendations by use of virtual telemedicine. I think that almost all of us will use virtual telemedicine as step one to get care for all things in the future and have a doctor or nurse or coach help us either solve the problem immediately and more conveniently, and if they can't, then recommend and actually make a better handoff to the next right place of care. We're going to all learn how to do this more, which is, events that used to be in person, do them virtually, and that will include sales and marketing and all forms of education. There'll be more personalization because we'll be able to tailor content to the audience as opposed to, on a one-to-one basis as opposed to one-to-many. Brick and mortar is going to become a special occasion. We will not go to stores or brick and mortar places as often as before for anything. There's a negative consequence of this making the socioeconomic class divide, I think, worse, because if you are blessed to have a safe home office and home Wi-Fi and be able to work from home, you can do a lot of this. If you rely on public transportation and need to be an essential worker, it's much, much harder. I think you'll also see the rise of offices at the edges of cities instead of large co-located locations, which will be more convenient and create less traffic, but also be a really different work experience. A slight silver lining is that I think that going forward, there'll be much more desire to invest in public health and social services, because what we're learning is that by taking better care of those who are most vulnerable, all of us are at lower risk of infection, and all of us can have a more vibrant economy and safer place to live and work and grow. And so I'm hopeful that this will help us attack issues like housing and healthcare inequities and access to healthcare. In California, we made a special effort to add our sample collection sites run by the state in places that are underserved. And what we're finding is that there's a tremendous need in those areas. And if we didn't do it, we would have a lot of the population that would actually not get access to care as quickly as they need it. Wrapping up, I'll offer you with kind of 3 benedictory comments. All of us need to do our part to reduce the number of contacts that we have with people per day, because it's more contacts leads to higher spread. And so please take this seriously and please wear a mask. If we lose our discipline here, we will give up the benefits that we've generated by virtue of the last 8 weeks of trying to prepare. And so it's important that we take this seriously. Containment can work, but we have to rapidly isolate people when they're infected and then test their contacts quickly. And then immunity is the answer here. And I pray to God that we have a vaccine that's effective. But even with the most aggressive vaccine clinical trials and Operation Warp Speed to manufacture it, realistically, a vaccine for most people is more than a year away. And so we need to actually prepare ourselves for the protections that we need to reduce the infection rate until we have that vaccine, because herd immunity will lead to way too many unnecessary deaths, and we should avoid that at all costs. With that, I'm going to pause and hand this to Dawn, who will share some really important insights, and then we'll come back and answer questions later. Thank you very much, Sami.
Yes, thank you so much, Bob, and especially thank you for your service to help the state of California and likely some other states as well in a, based on the presentation, very data and evidence-driven way. So thank you very much for that. Quick reminder for all of you who are tuning in, I already see questions coming in, so there is a function in the Zoom interface where you can ask questions. We will answer many or most of those questions at the very end. So please post your questions and we will answer those, or some of those questions at the very end. So next, let me introduce Dr. Don Berwick. Similar to Bob Kocher, I could spend half an hour reading Don's very extensive resume, so I'll again keep it very brief here. So Don Berwick, MD, is the President Emeritus and Senior Fellow at the Institute for Healthcare Improvement, or IHI as we call it. He's also the former administrator of the Centers for Medicare and Medicaid Services, or CMS. A pediatrician by background, Dr. Berwick has served on the faculty of the Harvard Medical School, and Harvard's Public School of Health, and on the staffs of Boston Children's Hospital Medical Center, Massachusetts General Hospital, and the Brigham and Women's Hospital. So with that, thank you so much, Dawn, for joining us today. I'll hand it over to you, and you can run the slides there. So thank you so much.
Thank you, Sami, and thank you all for joining us for this exploration. I look forward to your questions, and it's always a pleasure to join my colleague Bob Kocher in the pursuit of better information. I'm going to be talking a bit at a somewhat more broader level from Bob, not focusing so much on the phenomenology of COVID-19, but a little more on its consequences. And I'm going to move into some uncomfortable terrain. I warn you about the relationship between the COVID-19 experience and our experience of inequity and injustice in the American context. The initial stuff I'll share with you came from an article that I wrote for the Journal of the American Medical Association. I actually wrote it back in April of 2020. And the challenge that I was set was to try to describe what I thought would be the new normal. I rapidly came to see that I wasn't going to be able to do that. The best I could do would be to say what I think the dimensions of the normal context may be, and framed it in terms of choices that I think the virus is bringing us. There were 6 that I focused on in particular that I'm going to walk you through, and then I'm going to spend most of my time on the issue of inequity. So here are 6 things that COVID has brought us that I think represent choices as to how we want to conduct our affairs in the time ahead. The first is speed. In my career as a physician and a healthcare researcher, I've never seen things move as fast as they are now. Changes happening in delivery and knowledge, in relationships that go at a pace unprecedented. There's a canonical study in the health services research literature that shows that at the time of that study, the time from bench to bedside, from an innovation in care to its deployment at a large scale, was on the median was 17 years. We're very slow to spread good changes. In the COVID era, that's not happening. We're seeing nearly instantaneous spread. This topic came to my attention first when I was sent a document that was being circulated in Seattle between a bunch of Seattle intensive care doctors and intensive care doctors in Wuhan, who had formed a relationship and were taking knowledge immediately from the experiences in Wuhan right into Seattle. And I got that document in Boston because it took about a day for that document to reach Boston from Seattle. Journals are stepping up. The cycle times at the Journal of the American Medical Association, on whose oversight board I serve, have never been faster. The Institute of Medicine, now the National Academy of Medicine, famously rather slow and ponderous, although with plenty of gravitas, took 30 days between establishing a new subcommittee, a new standing committee on emerging infections and 21st century threats. And 30 days later, they produced 11 rapid expert consultation documents offering the country guidance. Internationally, the same thing. The Excel Center in East London, which was a conference center from the moment it was thought of to 30 days later, that's what it took to set up a 2,900 bed intensive care unit. Actually, it admitted its first patient 3 weeks after the idea surfaced of that conversion. Speed. Second is the nature of standardization. You know, in healthcare, we have a kind of ongoing combat between physician autonomy. It's my patient. I get to say, you can give me guidelines, but no rules. And people say, no, we have to make sure that care adheres to the best of science. And so we're going to have guidelines and protocols. That's melted away. I don't hear that debate. What I hear are clinical units reaching out all over the world for the best standards they can possibly find. Is there anyone out there that can tell me more about how to prone a patient, or should I use steroids? Or what about ventilator settings? There's a search for science and standards like I've never seen before. The third that Sami's already introduced and Bob talked about is virtual care. I spoke to a care system, a federally qualified health center system yesterday, who went from 5% virtual to 95% virtual in 1 week, and that's where they are right now. This is raising a somewhat larger topic, which I call proximity, which is I guess the bigger topic is we're learning what we don't need to do at a pace I've never seen before. I've always been skeptical about the necessity for a lot of routine visits and revisits. In the virtual care world, we're learning, as Bob said, to deliver care far more faster and more responsively and more agilely. And we're learning what care may not be needed. Especially some face-to-face visits. The way I would think about it is preserving face-to-face time for when it really counts. So we're not on a gerbil cage having patients spin through our offices. But that's only one example. We have this very interesting phenomenology of people during the COVID pandemic not showing up for other things. We're seeing a decrease in people showing up for heart attacks, for ambulatory pneumonias and other things. And you begin to wonder, well, what is going on here? Is it that a lot of the care that's used isn't needed? And I think we're going to get a lot of interesting health services research out of that in the time ahead. The fourth decision is, of course, how to protect the workforce, our attitudes toward the workforce. I celebrate, as anyone would, the applause in the windows of Milan or New York City for the healthcare workers. We call them heroes, and they are. And that includes a lot more than doctors and nurses. The people cleaning the rooms and moving the equipment around, they're healthcare workers too. We didn't protect them. They're still not protected. We still lack PPE. Bob said in California, a very well-off state, the PPE supply is still not what it needs to be now or in the future. The fifth is preparedness itself. It's got to be on the list. We were caught on our heels. We knew this was going to happen. There was plenty of warning, but we didn't respond, despite actually 2 decades of reports saying we're not prepared. And the last topic, cross-bridging everything, is inequity. And I want to dive into that one a little more. The inequity plays out in the COVID environment all over the place. This is an interesting slide that shows unemployment playing out in inequity. In Massachusetts, my state, we had a report just 2 weeks ago on vulnerability of jobs during the COVID epidemic. Look at the scale here. For people whose income band is $20,000 to $25,000 a year, 76% of their jobs are threatened in the COVID epidemic. For those at the higher levels of income, over $70,000 a year, that number is 2%. So there are very regressive economic effects of the pandemic and very regressive healthcare effects. This is another embarrassment in terms of inequity. This is the healthcare workforce itself. More than 800,000 healthcare workers and 1.1 million of their children live in poverty in the United States. There are over 1.4 million healthcare workers who have no health insurance at all. And believe me, this is not the doctors and nurses. These are the people at the lower end of the healthcare workforce. The inequity plays out also in racial and socioeconomic associations with COVID and its mortality rates. Overall now, for Black Americans, the death rate from COVID is about 2.4. It's actually a little bit more than that, 2.7 times as high as the rate for whites. It's also higher for Asians and Latinos. And I recently saw some data, which I don't think is published yet, which is that for people in the middle part of their lives, 25 to 49 years of age, the Black to white death ratio is 7 to 1. So we're seeing a highly inequitable play out of the effects of COVID on African Americans, people of color, and the poor. I want to talk a bit about poverty in this country because it's going to cycle back as a kind of takeaway from the whole COVID episode. Poverty rates in the United States are not low; they're high. Overall, in 2016, you see the rate of 12.7%, which much higher rates of poverty for people of color. 18% of kids in the United States live in poverty. 50% of the kids in the United States are born into Medicaid. What is poverty? The United States uses the federal poverty line to classify people as impoverished or not. I just want to give you some of the history of that. This woman's name was Mollie Orshansky. She worked in the Social Security Administration, which in 1963 was charged to define poverty. And the way Ms. Orshansky did it was logical. It turned out the Department of Agriculture had a food plan, which was the amount of money a family would be expected to spend on food during an emergency. Since food consumption was judged to be about a third of the American family income, Ms. Orshansky multiplied that number times 3, and that became the American poverty line. 3 times the bare essential amount of food you have to spend on food during an emergency. It's an extremely stringent view of poverty. Let's take another view of it, though, which is racism. This is redlining. This is what redlining looks like. You see the red marks on this map of San Francisco. That's where, according to the Homeowners Corporation, mortgages should not be issued because of racial distribution and hazard. This is the original redlining, in which race, poverty, and inequitable access to opportunity services. This is the map in San Francisco of the lowest performing public schools in the San Francisco area. This exact same geography as the red lines from the 1930s. This is the age-adjusted preventable hospitalization rate for adults in San Francisco a few years ago, exactly the same distribution as redlining. Poverty and racism and inequity infuse the American society. This is an example of a so-called subway map in New York City. That lower circle is Midtown Manhattan, where people average income is about $180,000 a year. 3 miles away, that upper circle is the South Bronx. And between the South Bronx and between the Midtown Manhattan and the South Bronx, when you get on that subway train, you lose 6 months for every minute, 6 months of life expectancy for every minute on the subway. 10-year difference in life expectancy. In Chicago, between the Chicago Loop and West Chicago, that's a 16-year difference. In Flint, Michigan, from poor to wealthy areas of Flint, that's a 15-year difference. That is an amazing amount of life lost, just associated with place, wealth, income, and race. So inequity pervades health status in America. We saw it play out in the COVID epidemic, and it's still there. What are we doing about it? And the answer is the wrong thing. This is a graph sent to me by my colleague, Sir Michael Marmot from England, who's a student of social determinants of health. It's the American tax rate. Effective tax rates between 1962 and 2018, according to one's income level. The bottom 50% of the population has seen an increase from 22.5% to 24.2% of their money going to taxes. The richest 400 people have plummeted from 54% to 23%. For the top 1%, it's 43 to 30%. This is regressive public finance as a characteristic of the American political economy. As a result, we do not distribute wealth in the correct direction. Our wealth distribution plan is from the least wealthy to the wealthiest, and the consequences play out in health. This is the child poverty rate in the United States, which is second highest among the 35 nations studied here, second to only Romania. The reason is that every other country in that list redistributes income in a progressive way instead of a regressive way in the US, and as a result, this is the rank of child well-being in the US in a 2013 UNICEF report, the last among 20 nations. We get what we pay for. With a regressive distributional policy for wealth, income, and social supports in the United States, we get lower health status. It plays out in life expectancy. This is the life expectancy in the US by year of birth. People born in 1920 over to people born in 1950. You can see the poorest 10% have had very little gain in life expectancy among men compared to the richest 10%. Women at the lowest levels of income in our country have actually had a decrease in life expectancy through the years 1920 to 1950, year of birth. This is the sequence we're trapped in. It's the COVID sequence. It's the play out in COVID of an underlying structure in American social policy, regressive policies, ungenerous in general to people of lower income and color, deep in poverty, increased isolation, deaths, so-called deaths of despair in the language of Angus Deaton and Ann Case, and poor health. And yes, more people in poverty, more people in lower income, more people of color die in the COVID epidemic than people who are better off. It's a tragedy for us all. I absolutely know that, and I'm not saying otherwise. But I think without attention to inequity as a fundamental determinant of health in America, we won't get health. Michael Marmot says inequities in power, money, and resources give rise to inequities in the conditions of daily life, which in turn lead to inequities in health. I can't close this without mentioning the play out in parallel with COVID epidemic in the United States, of the consequences of racism, as so tragically represented in the murder of George Floyd, and people now in the streets once again calling out the residue of our heritage of slavery and Jim Crow and racism in this nation. It plays out in COVID as well. So, I mean, the choices we have are here. For learning and change, we can decide to move quickly instead of slowly and moving knowledge around. We can commit to standardization to the best possible science and honoring science in everything we do in the pursuit of health and well-being. We can embrace this amazing high potential virtual care world with due attention to equity and quality of care, but really reconsidering the way we spend money in healthcare and what we're doing that's been wasteful that now can be replaced in a more modern information age. We can get much more serious about protecting the workforce, and that's not just PPE, that's really addressing human rights, well-being, and security in the workforce as a whole, including those people cleaning the rooms at night. We can now get serious about preparedness of this nation and finally say never again. We're not going to be caught on our heels again, even as we work our way out of this COVID tragedy. And most of all, I think, perhaps begin to take more seriously than we ever had before in the United States, this deep, deep problem of inequality and racism and exclusion at the foundation of poor health in America. That's going to take a lot of hard work and a lot of commitment, and I'm up for it. Thanks a lot, Sami, and I look forward to the questions.
Yeah, thank you very much, Don. That was wonderful, and somewhat selfishly, it was nice to see my original home country, Finland, twice there in the top 3 for child well-being. So that was nice to see. Again, my name is Sami Inkinen. I'm the CEO and co-founder of Virta Health, and I should say, for full disclosure, which I did not mention in the beginning, both Dr. Kocher and Dr. Bervik are on the Virta board of directors. So just wanted to share that for full disclosure. At Virta, we are on a mission to reverse type 2 diabetes in 100 million people, and we do that through a provider-led virtual clinic using individualized nutrition treatments to achieve those results. But what I'm going to mostly talk about for the next about 10 or so minutes is really about the evolution of telemedicine and why this evolution, I believe, is critical during the COVID-19 pandemic. And obviously, you already heard a few words about that from Dr. Kocher and Dr. Bervik. And then after this 10 minutes, we will spend the remaining time in a Q&A. So just as a final reminder, please post questions through the Q&A feature in this Zoom interface. All right, so let's see if I can move forward. All right. So these new virtual care delivery models are even more critical during this COVID-19 pandemic. And there's at least 2 reasons for that. The first one is the obvious, which you already heard from Bob and Don, which is, if possible, nobody should jump into a car, go into a doctor's office, sit there and wait there and meet somebody in person. So that's an obvious reason. If you can deliver care in a better way, in a virtual way, you should do that. But there's also a second reason, which is that people with chronic conditions such as cardiovascular disease or type 2 diabetes, in light of the reported data, has about 12 times higher probability of dying from COVID-19. So that's literally, I guess that's 11,000% higher mortality. And in order to deliver better outcomes in these chronic diseases, which is now all the more critical, we need better care delivery models. And just as one example, I highlighted here 2 chronic diseases that Virta can either, or we've demonstrated that we can either improve or reverse, and that is type 2 diabetes and then cardiovascular disease risk markers. So I'll go into some of those details in just a few minutes. But first, so I promised to talk about how we see the progression of telemedicine. And we basically see 3 phases or 3 transformations. And the first one is really where most of the, I guess, healthcare is today. That is, telemedicine allows the episodic in-person visits to happen virtually. So that could be as simple as picking the phone and calling the doctor, taking an app, or opening up a computer or laptop and having a virtual visit. And obviously this is wonderful, and there's been a lot of things that have enabled this. One example would be more generous ability to bill for telemedicine visits, and hospitals and providers are sort of scrambling to take the episodic in-person visits to virtual visits. And this is a very important step forward, but we see that it's only the step one. Step two is what we call continuous remote care, and this is what we deliver at Virta. And effectively, this is about going from episodic visits to continuous remote care, where we monitor patients multiple times a day and then proactively interface and communicate back and forth with the patients. I think Bob mentioned earlier this example that this type of a continuous remote care would allow checking in with the patient every single day, maybe multiple times every single day. And it may be completely obvious that if you're living with a chronic disease such as type 2 diabetes, it's a 24/7 thing. It doesn't only happen every 15 or for 15 minutes every month or every quarter, a couple of times a year, like we do in the episodic care delivery model. So that's the second transformation. The third one is enabled by this continuous remote care. And the third transformation that we see around chronic disease is that using continuous remote care, we actually address the underlying course of the disease and try to reverse these chronic diseases as opposed to just manage the symptoms. And the most obvious example for us in the Virta context is managing the symptoms of type 2 diabetes means prescribing medications to address high blood sugar. But if you can address the root cause nutritionally, you can actually reverse the entire disease. So these are the three steps that we see. And it's wonderful that most of the healthcare is in this transformation one, and we're delivering virtual care. But there are many more things that can be done for the benefit of patients as well as payers. So what kind of results are possible with this continuous remote care and focused on addressing the underlying course of these chronic diseases? So I'm just going to share a little bit about the results that we've seen in our Virta care. First, just to highlight, we've run a prospective clinical trial, published 6 peer-reviewed papers to date, and notably, American Diabetes Association included our outcomes and approach in their 2019 and 2020 care guidelines. So the results that I'm going to share here first are from our published and peer-reviewed results. So what is possible? For example, at 1 year, among the people living with type 2 diabetes that we treated in our clinical trial, 60%, so more than half, had type 2 diabetes reversed. And that means reducing blood sugar or bringing blood sugar or A1C down below the diabetes limit of 6.5% and eliminating all type 2 diabetes specific medications. And as a positive side effect, these patients also saw substantial weight loss and improvement in their cardiovascular disease risk score. Now, very relevant question is, what happens to the 40% who did not reverse their type 2 diabetes? The answer is they are on their way. So they've seen substantial improvement. So you can see here that RX elimination, so even this group was able to eliminate nearly half of their diabetes medications, while simultaneously bringing blood sugar or A1C down 1.2 percentage points, which according to most clinical trials beats any of the hypoglycemic drugs out there. And similarly, even this non-reversed group of patients saw substantial weight loss and improvement in cardiovascular disease risk score. So this is what's possible with continuous remote care and the right protocols. So again, talking about results, does this type of continuous remote care work in a real world? That was clinical trial. Clinical trials are always clinical trials. What I wanted to highlight here on this slide is just an example of some of the populations that we've treated at Virta. These are employer populations from white collar, blue collar, distributed office workers, US Foods, example of truck drivers, and then all the way to the right, the last column, we also work with the Veterans Administration. So this is US veterans nationwide. And the summary here is that if you look at any of these roles, glycemic improvement, A1C reduction, medication eliminations, and weight loss, we've been able to replicate or even improve the clinical trial results in quote unquote real world. So the continuous remote care approach and the protocols we use do work in the real world setting as well. Lastly, about results, equally relevant question then is, okay, so it works in real world, how about sustainability? Well, it turns out that ability to deliver a 24/7 support and again, check in with patients on a daily basis precisely allows us to deliver a very long-term result. So I will share here 3.5-year results on the Virta treatment. First, diabetes medication elimination. So you can see 60% of diabetes medications eliminated on average at 1 year, and then it's sustained and in fact even improved past 3.5 years. Same story with glycemic improvement. Again, it's more or less unheard of that you could eliminate diabetes medications and see improvement in blood sugar control, and similarly in weight loss. And this would not be possible without the continuous remote care that we use at Virta. So how exactly do we do this? And I will focus on the second part of the Virta offering. But first, again, we use individualized nutrition therapies to achieve these results biologically. But then secondly, on the right-hand side of this slide here is the virtual care and the virtual clinic platform that we built. And really key thing here is that we monitor our patients multiple times a day. We collect data from them, and then our care team proactively responds to whatever needs the patients might have. And perhaps most surprising to a lot of people is this is very intense patient management. We touch our patients virtually on average 3 times a day in the first few months of our treatment. So again, this is very intense care delivery, 3 touch points per day, when most chronic disease patients have maybe 3 touch points a quarter or 3 touch points a year. So continuous remote care allows this type of a highly intense care and patient management fully remotely. The last thing about our care that I wanted to mention is, so what is the provider experience? Again, Virta is a licensed provider in all 50 states. We employ full-time physicians, providers, and the experience of delivering continuous remote care is quite different from the episodic care and certainly from the in-person episodic care. So a couple of things here. First, the way we treat our patients, it is not a one-way street. Patient and provider are always co-pilots in their care and in their outcomes. So we individualize the treatment plans and constantly iterate. It's not that our providers just tell somebody to do something and then hope for the best, but it's sort of a co-pilot relationship, which is essential to deliver these outcomes. Secondly, we don't wait until something is wrong. We collect data, both blood-based and other biomarkers, multiple times a day, typically, and monitor our patients remotely. And then we use this data, or we run this data through software. We don't use software and technology to replace providers, but we use software, and I mentioned AI, artificial intelligence here, to provide our providers superpowers. So what that means in practice is we can make providers much more productive, much more effective, and we can really allocate their time on the patients that truly need their support. And of course, this makes it economically viable to interface with each of our patients on average 3 times a day. And again, the way we deliver care, it's not that we wait for something to be wrong, but we use the data to figure out which patients proactively need our care. And again, this is where high tech meets high touch. Everything we do is fully virtual. Our providers never physically touch our patients. So I'll just leave with this thought. chronic disease, it's a massive epidemic in itself, but COVID-19 certainly has made chronic diseases and type 2 diabetes specifically almost like a matter of death now. So the ability to improve outcomes, maybe reverse the disease and achieve that through continuous remote care is absolutely critical. And here's just an example of a patient quote from one of our Virta patients about, actually, I don't know, is it him or her experience during COVID-19 and how they appreciate the ability to deliver or receive care fully virtually. So we have about 10 minutes left, and I will, if I may ask Don and Bob to switch on your video so we can go into the Q&A, and I will try to moderate for the next 7 or 8 minutes that we have left. So we have a lot of questions coming in, so we don't have time to cover them all, but we'll answer some of these questions. And then there were already questions whether we'll share the materials. All the participants who tune in, we will have a recording of this webinar, so you will have access to all these materials and discussion that we had. So first question, maybe this is for Don, and then Bob, absolutely you should chime in as well. With social inequality and health disparities so pervasive in this country, and obviously amplified in a negative way by COVID-19, what are the quick wins to improve this situation? And maybe Don, maybe it means to repeat all the things that you just presented, but how would you say, what are the easiest ways to improve this situation?
Well, I think there are two, I think of it at two levels. One is for the immediate response to COVID. We have some challenges to make sure that care and help get to the people who have greatest disadvantage and highest risk, including people of color, communities of color. Bob can talk a bit more about that. They're addressing that in California. I think they really have that very much in mind. A lot of it has to do with healthcare insurance coverage. We still have a country where 30 million people lack insurance, 50 million people have underinsurance. And now in an employer-based insurance system, people are really at risk. They lose their jobs, they go on COBRA, and then they lose their insurance. And I think we need political leadership here to assure that, at least during the pandemic, healthcare is a human right. This is going to play out in vaccine testing and treatment access. We're going to need American healthcare policy to be very clear that the size of your wallet and the color of your skin will not determine whether you have access to effective treatments once available, and certainly to vaccine once available. This should be raised in the matter of public policy. Unfortunately, there's a political edge to it all. In the longer run, we actually have a great deal of information about what kinds of investments do redress the inequities we're talking about. They're where you might think: investments in early childhood and early child support and safe birthing, investments in strong education. If you have $1 to spend more for American health, I actually don't think you'd spend it in healthcare. You'd probably spend it in education, the educational system. That's where people acquire opportunity and self-esteem and security. We have big problems. We have hunger, 40 million people currently with food insecurity in this country, 600,000 chronically homeless. This is a country wealthy enough to solve those problems. So we need leadership and public investment. Immediate results? No, but within a few years, we could do a lot better once we make a decision to do that. It's as much a values issue as it is a technical one. Bob, you may want to say more about how California.
Well, I agree with all of those comments. I would add a couple near-term things. I wrote a letter with many other healthcare policy folks to Congress, asking them to create a special enrollment period for the duration of COVID-19. The people who lose insurance can immediately enroll in health plans in the individual market. That's really important because the employer-based system is problematic right now in the sense that if you lose your job, you may have coverage for a few more weeks, but then you need to find coverage, and you need coverage because we're having a pandemic. And so ensuring people can access new insurance is super important. I spent my life trying to make that insurance more affordable. There's more that we can do to make that insurance more affordable, and we owe it to our country to do that. We also need to create incentives for states that chose not to expand Medicaid to do that, because Medicaid is the place where those who are at greatest risk get insurance. To create more access to healthcare, we also need to have Medicaid pay higher prices to providers to deliver the care, so we will get more care for those patients. The reason we have underserved areas is in part because Medicaid in many states doesn't pay enough to support the investment in healthcare services that those patients deserve. And so we need to work on fixing Medicaid to be more equitable, such that providers can serve those patients. And then I think we need to make special investments, as I alluded to in my last slide, around public health. Homelessness is a giant public health problem and making COVID worse. We should address it. It's addressable. Nursing homes are important because people who are frail and vulnerable need care. Right now, they're not as safe as they could be. And so we need to make them safer. We'll save lots of lives by investing in homelessness and nursing home safety. And Don's certainly right, longer term, for all of us, education is the answer. And so we need to create opportunities for people. And I hope that we as a country embrace those priorities as fully as Don and I have embraced them and believe in them.
Well, thank you both. There were lots of policy change ideas, and hopefully not just ideas. It sounds like extremely important for our collective health and well-being as a society. Let's see, we have a lot of questions coming in, and again, I promise that we will answer some of these questions offline with people as well. Let's take a telemedicine question. What are some of the promising examples of innovation in telemedicine that you've seen so far that is setting an example for the rest of the industry? And feel free to ignore Virta. I'm sure you want to say that Virta is doing a great job, but any examples of telemedicine innovation that you'd like to mention?
I'll be quick and I'll offer a couple. One is Medicare, thankfully, has allowed all Medicare beneficiaries to access telemedicine for the first time as a result of the pandemic. And what's been really exciting is that Medicare beneficiaries have, as you would expect, learned how to use telemedicine and embrace it. And so the uptake of telemedicine among those over 65 has been astonishing. And what happened? They like it. Their Net Promoter scores are high, the quality of care appears to be high, and emergency room visits have been avoided. What I think has been really wonderful is that for the sickest among us, telemedicine, as I alluded to, it's been used by lots of primary care doctors to do daily check-ins with people and daily adjustments of medications and daily assessments of food security and of safety. And that's led to a bunch of things being identified that wouldn't have been picked up in a regular doctor visit. And so I think that there'll be continued exciting improvements in how telemedicine sort of enables that type of care, coupled with the data streams that you can get now from whether it's a ketone meter or glucose meter or scale or thermometer or sleep studies to help improve the actual effectiveness of care in ways that we couldn't before.
I'll just say I'm pretty excited about what I'm seeing. Just before the COVID struck, I was at Northwell Health System in New York City, for example, where I visited their telemedicine unit, this extended unit with everything, Tele-X. It's being done with Philips Corporation. Sure, telehealth, but telestroke, teledermatology, ALS, telepsychiatry being picked up very avidly by both the clinicians and the communities at large. I watched an intensive care doctor at a bank of computers doing tele-intensive care in hospitals 50 or 100 miles away, I think, with patients he knew. He knew those patients from the day before and the day before that, coaching the local staff on ventilator adjustments, medication use, psychiatric support. One doctor serving 5 or 6 people over a region of, I bet, 100 square miles. Pretty exciting. There's also one other quick thing I'll mention, which is I don't know what to call it. It's telecoaching of the clinicians. Dr. Sanjeev Arora, one of my heroes, Dr. Arora at University of New Mexico in Albuquerque, now 15 years ago, set up the ECHO project, which all of you should Google, Project ECHO. That's a telecoaching of staff, including not just physicians, but advanced practice nurses and physician's assistants, community health workers, not just in the United States, but in countries all over the world, from an academic medical center. He calls it a force multiplier, deploying knowledge of the best possible way to take care of very complex conditions at very low marginal cost with extremely high efficacy. That's another form of telemedicine I think is tremendous potential.
Yeah, sure.
Yeah, thank you. Let's do one more question. So quick answers from both. And with regard to telemedicine, by the way, it feels like the arrival of the future has accelerated by 2 to 5 years. So it's actually wonderful that is happening. So one question and brief answers from both of you. where should US, the United States, be putting its resources now before the next wave of COVID-19, or, you know, we may debate whether it's the continuation of the first wave, but where should US be putting its resources now before the next wave, which will coincide with the flu season? What are your thoughts?
I guess I'd say two things. We need to make sure that we have enough PPE to have all healthcare workers and essential workers be safe. I'm not confident that that's the case everywhere in the country, and so that's first. Secondly, we need to put in place exquisitely good screening testing of people in high-risk settings like nursing homes, prisons, homeless shelters, and for the workers who are working with those populations, because very quickly you could have infections starting to come out of control in those highest risk locations. Then for population-based testing, we need to have screening of people, so we pick up the asymptomatic cases, and then excellent access for anybody who has any symptoms.
Yeah, I'd add to that absolutely PPE and testing. Testing is absolutely key. A couple of the thoughts I would add is support CDC. I think the concept of anything other than 100% support for that amazing organization is a bad decision, and we need to beef up CDC's capacity. They're absolutely invaluable. I'll say the same for the World Health Organization. We are, after all, part of a global pandemic, and if we don't participate fully in the global regime for dealing with this pandemic and public health in general, that's a massive mistake that's going to go back to haunt us. So please get WHO back on the screen and fully supported with as much American support as we can put in that direction. That will help us a lot.
Yes, for sure.
Well, again, thank you both, Don and Bob. Every time I listen to you, it feels like I'm going to school. So again, I learn a lot, and thank you so much for your leadership, both on a local and national level. And thank you to all the hundreds of people who joined today. Again, we will share the content with all of you. We will likely get back to those people who asked questions that we didn't have time to answer. So we do want to answer those questions. So thank you so much, Don and Bob, and I really appreciate you taking the time.
Thank you.
Have a good day and stay safe.
Thank you. Bye-bye, everybody.